in the last session I forgot to mention one thing, not very required, no one will ask, but these are groups attached to the at different positions. The protoporphyrin ring, this, if you want to draw, don't draw such complicated picture. I will suggest not to draw these. It is although you must be well versed in chemistry, at least than me. I have studied it so many years ago, but I think you know about these structures. You know, you are good in organic chemistry. I hope that, but still don't try to draw. It will take time in the exam. You draw this ring as, name this ring as, say you name it as pyrrole, and write, this is how to answers and save times in the exam, right? P for pyrrole ring. So, but if you want to name the groups, then you have to position, you have to remember that it starts from 1 and it comes clockwise and ends at 8, and different groups are attached. So, different groups are attached, vinyl groups, methyl groups, propionic groups, those are attached. You don't have to write this CH2 and all, don't write like that. Just when answering questions, write, say V for vinyl, and mention that V means vinyl group. I think the physiology examiners, no one will ask you for, or no one will expect that you show the actual structure of vinyl. So, write V over there and write V for vinyl group. I will show you one slide how to do it. So, here they have, see, this looks complicated, but if you write like V, or where it is propionic acid, if you write like PR or something, but you have to mention those are not universally accepted these abbreviations. So, you have to mention PR means what, otherwise it is wrong. Otherwise the examiner may discredit you, that what is this. But if you mention, that is okay for answering a question on hemoglobin structure. Okay, see, you pyrrole ring, or you can draw once like this, write pyrrole ring, in bracket write P. This is how to answer questions. This is nothing, that is, you should know how to answer questions. What is the trick of saving time? Pyrrole ring P, and write, when you draw the whole structure, write only P. Okay, and attach the groups. This is deoxygenated hemoglobin. You see here oxygen it is attached. This is oxygenated hemoglobin. And what is the term? This is oxidation or oxygenation of hemoglobin mentioned. Oxygenation, not oxidation. Oxidation is losing of electrons and all, whatever. Again, you know chemistry better than me. That is not relevant here. And iron is in ferrous state or ferric state. These will help you in MCQs also. These terms, all these things, these are easy things relatively, but all MCQs, some MCQs can be tough, but some will be easy. So, it is in ferrous state. In ferric state, if it becomes ferric state, what is it called? Meth hemoglobin. It is called meth hemoglobin. Okay. So, those are again some structural variants, not the variants we will study about. We will study about the variations mainly in the Globin chains. Those are being called as variants. What variants you see mentioned in your syllabus, but oxyhemoglobin, carbamino hemoglobin, when hemoglobin attaches to or it carries carbon dioxide, meth hemoglobin is Fe3 plus instead of Fe2 plus, that is ferric instead of iron. These are about the Globin chains, 2 alpha and 2 beta in the adult hemoglobin, which is written as capital H, then small b and a. These are almost universally accepted, but still I would suggest, without mentioning what it is, don't just write abbreviations in the exam. Situation is a bit tricky. Sometimes MCQs will give you abbreviations, you have to know them. But if you, like I mentioned in the last session, I think, in this class or in the nursing class, that WHO stands for World Health Organization. That is more or less well accepted. At least in when we are discussing about health, medicine and all these things, WHO means World Health Organization. That is more or less accepted. Everybody knows it is still acceptable, but there will be abbreviations given which sometimes you have to face as students, nothing to do, and you have to understand that. But I think you should write at least once in the answer. When you are answering a question, first you write the full form, write in bracket the abbreviation. For the rest of the same answer to the same question, you go on writing the abbreviation, that's okay. That's how to answer questions. This is about chromosomes 11 and 16, one for beta globin chains, one for alpha globin chains. These were beta cluster means beta, gamma, delta, epsilon, and alpha and 2. See this epsilon and this zeta, all these chains. This is about the rate of formation. We will come back to this if required today also. Rate of formation in the adult. See, beta chains are not very that relevant. This is on the x-axis is birth. Before birth, beta chains are small in number. Alpha chains are taking a pace, rate of formation of alpha chains at about the second month or so. And see, in the whole of life, it is almost 50%. It is alpha chain. 4 chains, so 2 are alpha, 2 are something else, mostly it is beta, hemoglobin A in the adults, beta chain is taking upper hand, some delta chains, alpha 2, delta 2, gamma chains in the fetal life, alpha 2, gamma 2, that is fetal hemoglobin, and gamma chains are falling after birth. The rate of formation of gamma chains are falling after birth, but you will get such graphs everywhere in your syllabus, everywhere while studying this. All these things, physiology, medicine, whatever, you will get some graphs. See, whenever it is not touching the baseline, it means it does not become 0. That means most probably, and this is from a very standard textbook, that gamma chains are continued to being formed throughout life, but very little in amount. So, throughout life, some amount of fetal hemoglobin is, it's alpha 2, gamma 2, it is present in adults also, maybe less than 1 to 2% maximum, or even less than that. But at least some amount, because gamma chains are not touching this baseline. This is the graph for the formation of all these globin chains. This was only about globin versus globulin. Globin versus globulin. This is, globulin is not related strictly actually to the hemoglobin discussion, but what we mentioned, like don't confuse between hemostasis and homeostasis. Like don't confuse between globin versus globulin. Globulin has been discussed in plasma proteins, major plasma proteins. The most abundant one is which one? Those who are new, what is the most abundant plasma protein? You should know this from, it's albumin, okay. So theory classes can't be repeated, you have to cope up, those who are new. So know from your friends what have been taught, go through the syllabus, study. If you have any issues, then contact us, but theory classes can't be repeated at all. So plasma proteins have been discussed, albumin followed by globulin and other plasma proteins, so many, over 200, 300 plasma proteins are there. You don't need the extensive list, but you have to know the names of albumin, globulin, at least the plasma proteins which are helping in hemostasis like fibrinogen and all. So globulin is a plasma protein that is in no way, that is in different from globin, and please keep a note of that. In the exam, don't confuse between globulin and globin. Don't confuse between homeostasis and hemostasis. Okay. What is myoglobin? Again, another similar protein which can carry only one oxygen molecule. It is present in muscles. Hemoglobin synthesis, again same thing, pyrrole to protoporphyrin ring, that which was just shown. Hemoglobin synthesis, 2 alpha chains, 2 beta chains. This is adult hemoglobin, and these are from succinyl CoA and glycine. Delta, this is in many in biochemistry books you will written this as delta amino levulinic acid, DALA. DALA means delta, that not D but delta, then ALA, capital A, capital A, capital L, capital A. I am not writing everything, it will take much time. You will find everything in the books, nothing to write down, okay. And for the new ones, don't take pictures in the class, that is not allowed. These are from either from the internet, just you can search it, these figures in the internet, or from standard textbooks. And standard textbooks, as you know, can't be any textbook. It is not, that means we don't have the right to copy. You know that? Copyright, okay. But in India, copyright means right to copy. But we actually, that is no right to copy. So it occurs both in the cytoplasm and in the mitochondria. I think more of it, physiology and biochemistry was once the same subject in the curriculum years back, not when even I studied MBBS, but years back, maybe 30-40 years back. So now I think maybe the steps may be asked more in biochemistry, also in physiology, but I think more in biochemistry, which of the steps occur in the cytoplasm, which occurs in the mitochondria, and mitochondria of which cell? Which cell? Mitochondria, this means mitochondria of which cell? Blood cell. Which blood cell? So, again the answer has to be complete. Mitochondria of which cell? This is a very easy thing to say. Bone marrow has mitochondria. There has to be some cells. Yes, RBCs are produced in the bone marrow. So, the complete answer will be mitochondria of maturing RBCs. Does adult RBCs have a mitochondria? No. So, maturing RBCs, where does hemoglobin synthesis? We are still on with last day's discussion. We have not yet started today's discussion. Where does RBC synthesis take place? That is bone marrow and all. Bone marrow, then yolk sac, liver, spleen, then bone marrow. That's. Please try to relate. Otherwise, in 9 months, you can't cover all these things if you can't answer a simple question. Hemoglobin forms in the maturing RBCs, starts appearing at the intermediate normoblast stage, which is equivalent to this one, polychromatophil erythroblast. In books you will find these 3 erythroblasts, also called normoblasts. This is those who are new, all these things, whatever books you study, you have to study one physiology textbook at least. So, you will get these things. Normoblast is another name for erythroblast. Blast cells are immature cells. Basophilic erythroblast also early normoblast, or polychromatophil erythroblast or intermediate normoblast, orthochromatic erythroblast or late normoblast. So, MCQs if you have to tackle, you have to know both terms. Not only MCQs, wherever you find what is erythroblast, what is normoblast, these are the same things which we are calling early, late and intermediate. Hemoglobin starts appearing in intermediate normoblast stage. See, after the reticular exocytosis of nucleus, RBCs become, mature RBCs are non-nucleated and devoid of mitochondria, okay, devoid of mitochondria, also ribosomes. So, nucleated exocytosis of nucleus occurs in the after the orthochromatic erythroblast stage, before the reticulocyte stage, roughly. So, reticulocytes are already anucleated, but loss of mitochondria and cytoplasm ribosomes from in the reticulocyte stage to the erythrocyte, when it becomes the mature erythrocyte, mitochondria are also lost. So, mitochondria will not be there in adult RBCs. So, hemoglobin synthesis occurs in, that is heme synthesis occurs in maturing RBCs, starts from the intermediate normoblast stage. So, these are all potential MCQs plus short notes and everything. Not, I think not long questions, but short notes is cytoplasm and mitochondria, both hemoglobin synthesis. These are the again the detailed steps with the enzymes. More you have to deal in biochemistry, but these are the with the enzymes, which is the rate limiting step, glycine plus succinylcholine equal to this what was calling delta ALA, amino levulinic acid. That is the rate limiting steps. These are the different combinations of the globin chains. So, Goward, Portland, these names are historical again. Goward is the place of a name of a place, Portland is the name of the place where it was first discovered. So, all these are of historical importance. But fetal hemoglobin types can be these, adult hemoglobin types, see, fetal hemoglobin continues at least in some amounts throughout life. Okay, functions of hemoglobin, oxygen, carbon dioxide transport is pretty easy, but buffering blood pH, hemoglobin has buffering action, acid base balance, hemoglobin can combine to H plus, okay, and during, and buffering action means neutralizing. This buffering means neutralizing. This is about mostly about acid base balance. What we mentioned, source of physiological active catabolites, rather it is from hemoglobin breakdown. It should not be strictly called a function. Genetic resistance to malaria during sickle cell hemoglobin, sickle cell anemia. We will discuss about sickle cell anemia in short today. Sickle cell anemia actually that is should not be called a function. They have sickle cells, they have genetic resistance to malaria, Plasmodium falciparum or Plasmodium cannot survive in those types of conditions. So, that has a genetic resistance to malaria, but calling it a function of hemoglobin is rather foolish. But go for these four: oxygen transport, carbon dioxide transport or carbon dioxide removal, that is carbon dioxide transport and removal, buffering of blood pH and blood flow, regulation of blood flow through nitric oxide. This is carbamino hemoglobin combining to carbon dioxide. Globin combines to carbon dioxide, but for the combination of oxygen or oxygenation, heme is required, heme part. And again, it may help you tackling MCQs, and you may write wherever it is you feel relevant. Don't write irrelevant things in the exam, but wherever you feel relevant, you can mention this, that carbon dioxide is, globin is required for attachment to carbon dioxide. It forms carbamino hemoglobin through NH2 amino groups. For attaching to this formation of oxyhemoglobin, heme part is required, and cooperative binding means one oxygen, when it binds it, the affinity for another oxygen increases. We will mention when we will study the respiratory system, you will see the curve, hemoglobin, oxygenated hemoglobin, how does hemoglobin combine with oxygen and how the curve looks like, because one increases the affinity for another. So, there is a specific shape of the curve, it is called sigmoid. We will discuss this in the respiratory system. This is hemoglobin can bind to nitric oxide, and that is how it is regulated, because nitric oxide is a vasodilator, dilates blood vessels, that is in some way it has a role in regulating blood flow. Whenever hemoglobin is deoxygenated, it is giving, that is oxygen is being supplied to the tissues, it also releases nitric oxide, okay. So that this oxygen can reach the tissues through dilated blood vessels. This is what is the concept is telling, that along with oxygen, nitric oxide is also released. So, the blood vessels dilated and oxygen reaches the tissues better through those dilated blood vessels. So, this is about hemoglobin breakdown. I have already mentioned in short last day. So, heme plus globin again broken down, globin again reutilized, heme part from the iron again it is in the as apoferritin, as transferrin, these are all again some plasma proteins. These proteins are in the plasma. So, these liver makes many of the plasma proteins, most of the plasma proteins. So, these storage apoferritin in the liver and all. So, iron again reutilized, globin again reutilized, and this heme part, this protoporphyrin part is breaking down to form biliverdin and bilirubin. You have heard those names while studying GI physiology. You have heard all these names. You know a bit about jaundice. We will try to discuss it again here, I think in the next session or after that, but in the GI system you have come across these terms, biliverdin, bilirubin. So, oxidized by heme oxygenase protoporphyrin, then biliverdin is a green pigment and bilirubin looks yellow orange due to this structural, whatever structural characteristics are there. So, biliverdin is green, bilirubin is yellow. So, it is biliverdin can be called a tetrapyrrole, again pyrrole chain free from globin and iron. Iron and globin are reutilized in the body. Globin enters the amino acid pool, all these things, and hemoglobin split off in the, so RBC breakdown in the tissue macrophage system in the spleen. Tissue macrophage, what is macrophage? Macrophage are converted which cells? So, see this is protoporphyrin, see these rings again they have, see here they have mentioned also this MPV, but you have to label at the side. So, these are from standard textbooks, I have not brought those labels I have not brought. So, they are mentioning what is M, what is V, what is P. I have just cut it, just cropped it short, but what is MVP you have to mention, vinyl group, methyl group, propionic acid group, that you have to mention. If you draw any structure like this, even you do not need to write NH and O, you just mention pyrrole ring and whatever P, but draw a ring, P is for pyrrole, PR is for propionic acid group, M is for methyl group, V. But if you draw a diagram like that, it will help you save time, but if you do not mention those abbreviations, that is discredit. Biliverdin reductase to bilirubin. Heme degradation, this is again showing the, this has become very small also. This is again whatever we have mentioned in that slide, breaking down of hemoglobin. So, globin reutilized, again we have already mentioned adult hemoglobin is HbA. What is the time? So, we are starting after 9:30 actually. Common types of hemoglobin adult HbA, one is HbA1, alpha to beta, HbA1, that is some call it HbA1, some authors, that is what is HbA we are calling, but HbA2 some are alpha to delta 2. Again go back to that, see this is the formation rate of formation of chains. So, delta chains start appearing just before birth, and it remains at low levels throughout life. Maybe somewhat in the later after the age of 5 months or so, somewhat more than gamma chains. So what is the order in, say, most abundant is in the adults is after the age of few months only, it will become, see, after the age of few months, see, at this point 5 months alpha 2 beta 2 is main hemoglobin A, or some authors calling hemoglobin A1, HbA1, A1 and A is same. That means if you get A1, take it for hemoglobin A, which is 98 to 99% of adult hemoglobin from the 5th month onwards. Next in abundance is what? Alpha 2 delta 2, that is HbA2, and least is beta 2. Abundant word is not correct here. Abundance, the word means plenty. So abundant only one is HbA1 or HbA, but simply HbA. HbA2 and HbF are very small amounts. A2 is probably somewhat more than F. Again, this shows this gamma from the, this is about, say, 5 months. So gamma is coming down, but it does not touch the 0 line. Okay. So that's what is the summary. So see again, this is A2 is they are calling 2 to 3%, fetal hemoglobin in adults is less than 1%. This is the percentage showing again percentage of hemoglobin A at different stages. So pre-birth and post-birth, you don't have to remember every figure, and these will be obvious things. You have to just know what is, nobody will ask you what is the percentage at 20 weeks of intrauterine life. No, not like that, but this is just a figure that is, say, at 4 months. Again, if you go to that, what I just mentioned is around the 5th month of age, it is gradually, it becomes 99%. After 6 months, 99% is adult hemoglobin, alpha 2, beta 2. So that is what is written. From the 4th month, about the 4th month, it is 90%. 2 months, it is 50%. That is hemoglobin A. Hemoglobin A2 and F are gradually coming down. That means in proportion. And after 6 months, 99 months, more than 6 months or 1 year, 99%, more than 99% may be HbA or HbA1. Again, it varies. Nothing is 2 plus 2, 4 in medicine. It may be 97, 98, 99% in that range. Fetal hemoglobin, again alpha 2 delta 2, it is ability to bind oxygen. What is the most important property of fetal hemoglobin? Ability to bind oxygen is, ability to bind oxygen is more than adult hemoglobin. Okay. Better access to oxygen from the mother's blood stream. That is what is the most important property differentiating fetal hemoglobin from adult hemoglobin. Delta chains are structural differences. So I think if it is mentioned, say a short note, or I don't think these types of questions come now. Difference between adult hemoglobin or fetal hemoglobin, or 2 mark question in another question, that has been, I think, removed from your question pattern. Earlier it was 15 marks question, 10 marks question, again part wise it was divided, say 1 plus 7 plus 2 like this. So differentiate between adult hemoglobin and fetal hemoglobin, you can write the structure, you can make a column, write structural differences, difference in the globin chains, functional differences, difference in property, about carrying oxygen, what is the proportion. So what is the proportion of fetal hemoglobin? Fetal hemoglobin is the only hemoglobin, it is the only type according to the structural that is present in fetal life as well as adult life, although very minute in amounts. Okay, you can write the differences like that, making a table. And increased resistance to alkalis, it is one property. Decreased action with 2,3-BPG, we will know more about 2,3-BPG, it is bisphosphoglycerate, it is an enzyme present in the RBCs. So that is, we will know more about it when you will discuss, or we will discuss, or you will know about the respiratory system. We have to discuss a bit about the variants of hemoglobin. It is hemoglobinopathies are diseases, that means it refers to diseases related to this hemoglobin synthesis, structure, functions, hemoglobin structure and structural abnormalities. Pathies, we classify it, or it is convenient to study it as, like, see, in some cases, just follow the red dot, production of abnormal hemoglobin molecule due to structural abnormalities in these globin chains, structural abnormalities. So One may be due to structural abnormalities, one may be due to quantity of globin chains formed are less. All these terms both are covered by hemoglobinopathies. Some authors are writing it like hemoglobinopathies differs from these insufficient quantities. Example, thalassemias, they are hemoglobinopathies. Some authors are describing it like this: hemoglobinopathies cover only structural abnormalities, but no, you say hemoglobinopathies. So, pathology, study of diseases; physiology, study of normal bodily functions; pathology, study of diseases. Hemoglobinopathies relate to all these diseases which are related to either structural abnormalities or synthesis of insufficient quantities, but structurally or properties wise they are normal hemoglobin, but reduced synthesis. Best example is thalassemias, rarely combination of both. So, that will lead to more problems obviously. Structurally also there are problems for reduced quantities, all there will be problems, and hemoglobinopathies are mostly this is passed on from one generation to another, hereditary issues. Okay. So, and thalassemia, which is more discussed, the name thalassemia coming from, again there is some word thalas, means I think thalas means these are all Latin derivations, ACAC. So, first one type of thalassemia is Cooley's thalassemia, named after some doctor, just I can't recall the full name right now, Dr. Cooley, in the Mediterranean region. It was first and it is more prevalent in those populations, more in Mediterranean populations. So, the origin of the word is from that. It is a group of inherited disorders. This is mostly due to synthesis of reduced amounts of hemoglobin, thalassemia. See, group of characterized by reduced or absent of one or more of the globin chains, and two classically known thalassemias are alpha and beta. So, which of the globin chains are absent, which of the globin chains are present, combination or something, these are alpha beta thalassemia, these are the most known. So, these are reduction in the globin chains which are present may be normal, but due to reduced synthesis or absent or one or more of the globin chains. If there are 4 globin chains, so I am just giving one just to exemplify, or just arbitrarily say one beta chain is absent. So, there are 3 alpha and 1 beta, it is related to, it will become the functions of the hemoglobin can't be carried out properly. So, 3 alpha 1 beta, it should be 2 alpha and 2 beta. Okay. Types are alpha and beta. This is 4 genes are responsible for alpha, 4 genes are responsible for alpha thalassemia. It may be abnormality in one or more of those 4 genes. For beta thalassemia, 2 genes are responsible. Again, this bit of information may help you in tackling some MCQs. 2 genes for, and beta on which chromosome? It's, so beta comes after alpha, but beta is 11, alpha is 16. Okay. Again, I am referring these just if you get MCQs, you remember and mark accordingly. But genes number are 4 for alpha, that means 4 genes, not all 4 will be involved always. If all the 4 genes are involved, it will be more severe. It may be 1 or more of those 4. In case of beta, it is caused by 2. So, this has become a bit hazy. 4 genes are involved, is 1 or 2, then it is minor. Alpha thalassemia major for 3 or 4. It is if 1 mutated gene or 2 mutated genes, it is alpha thalassemia. Minor, this major and minor relates to the severity of the disease. This major and minor, again beta thalassemia major and minor, this relates to the severity of the disease. Do not worry, everything is in the books. It has become a bit hazy, this slide, just because of the, I think, the color reflection and all. So, alpha thalassemias, I told 3 or 4 genes may be involved, 1 or 2 genes may be any 1, 2, 3 or 4. So, 1 is the most. If only 1 gene is involved, the disease severity will be obviously much less. So, that is what is written over here. You do not have to worry that nothing is missing and everything is given in the books. For beta thalassemia major or intermedia, there are 3 types: minor beta thalassemia minor, beta thalassemia major, beta thalassemia intermedia. In case of minor, one gene is involved. In case of intermedia or major, both genes are involved. But why what is the difference between intermedia and major? That is not according to the number of genes, but severity depends on other factors also. So, those are clinical things, that what is the, that is clinical relevance, that it is what is the severity of the disease, how is the severity of the disease, according to that it is thalassemia intermedia or minor. Alpha thalassemia, again see, one of the 4 genes involved, chromosome number 16, one of the 4 genes involved, it is called thalassemia trait, or one of the 4 genes involved, it is just silent carrier. So, severity increases with the number of, clinical severity also increases with the more number of genes involved. It is asymptomatic. What is the meaning of symptom? Those who are new, what is symptom? Do you know what is symptom? Symptom is the presentation or the complaints of a, say somebody comes to the medical professional and says I have fever. So, fever is the symptom, I have headache. So, these are symptoms. Asymptomatic means usually, so the individual will, if it is completely asymptomatic, the individual won't find it out, won't face any problem. So, symptoms are those characteristics which are explained, or before explained, which are mentioned by the individual who comes for medical advice, and sign is what the clinician or the medical professional elicits. Okay. For those who are new, these terms are maybe new, but you have to know it. Okay. So, difference between sign and symptom. So, asymptomatic means probably the individual will not face any problem, and this would be, that would be incidental finding. Okay. When, if at all this, there is some diagnosis, that will be incidental diagnosis at a later stage. Suppose some individual has come for another thing, so for the treatment of some other symptom, but somehow by lab investigations and all, these are established. So, that is alpha thalassemia silent carrier or trait, where even 1 or 2 of the 4 genes involved, they are clinically asymptomatic, but 3 or 4 genes involved, severity will increase, there will be there will be symptoms. Hemolysis, if there is hemolysis, oxygen carriage will be hampered and there will be symptoms. The individuals will face some, there will be some issues which he or she will complain of. So, there will be symptoms. Hemoglobin, alpha thalassemia silent carrier trait, we will mention what is hemoglobin H disease. Again, HB Barts, again these are historical references, the name came from somewhere. HB Barts is alpha thalassemia major, where 4 genes are involved. Barts, hemoglobin, that is called hemoglobin Barts. All the 4 genes are involved, and due to anemia, jaundice breakdown, it may cause something called hydros fetalis. We will again discuss during discussion on blood groups. Hydros fetalis, simply know this is accumulation of fluid in various body compartments in the fetus, that is called hydros fetalis. Okay, or what we know as edema. In adults, we know about edema, accumulation of tissues, fluid in tissue spaces, accumulation of fluid in various compartments inside the fetus, that is called hydros fetalis. This hydros fetalis can be seen in this when all of the 4 genes are involved. Beta thalassemia, similarly, 1 gene affected, it is just a carrier or trait, maybe a silent carrier, or it is called a beta thalassemia trait. But if 2 genes involved, then it may be intermedia, according to the severity depends on some other factors also, intermedia or beta thalassemia major, and this is just showing 1 gene. So, combination, if the father carries, if one parent carries 1 abnormal gene and 1 normal gene, then the various combinations which may be there, if this fetus gets both the abnormal genes, or it better to call it here, what is a better term, instead of calling it gene when it is being carried to the father to the mother, the term starts with A, allele, yes, that is allele. Then it is moderate or severe anemia when both the genes, the abnormal genes are carried both from one from each parent. Okay. So, again major beta thalassemia we mentioned, this is called Cooley's anemia. Cooley is the name of the, just full name I can't recall just right now. It is Cooley's anemia or Mediterranean anemia, due to first it was established in that region, in the Mediterranean region. So, it is Mediterranean anemia. And minor beta thalassemia, obviously less severe symptoms, the patient survives longer. In major beta thalassemia, probably in spite of repeated blood transfusion, firstly it is a very grave disease in the form of the That means the life quality of life becomes very poor from the say almost after birth, and repeated blood transfusions required every month, every 15 days the child has to get admitted, hospitalized and get repeated blood transfusions. Quality of life is very poor, and probably beyond 2 decades life is not, that means it is not possible, that means death occurs. It is fatal within 2 decades, sometimes within 2, maybe 3 decades maximum. The person won't live beyond 2 or 3 decades. So that's the sad part. Obviously diseases can't be, that means there is nothing to be happy about a disease, but still in minor beta thalassemia probably the life span is longer and the patient survives up to adult life. But again, if the patient survives up to adult life, so thalassemia, this thing you all know, common knowledge, thalassemia should be screened before marriage, right? These things you should be knowing. This is, so it should be screened before marriage, because it can transmit the gene to the offspring. Again we showed, if the allele, if it is heterozygous in the both the parents, then at least 25% chance there is to be passed on to the child. And I may sound a bit philosophical, but nobody will want that some grave disease is passed on to the child, because if it is the parents are heterozygous and it is passed on to the child, then that child probably won't be living beyond 2 decades. So that is what thalassemia, this is common knowledge. Thalassemia should be screened before marriage, and if at all they should, that couple should get married, they should not take a child, right? Again, this is just everything we have mentioned, whatever is there, a table comparing alpha and beta thalassemia. If there is a difference between alpha and beta thalassemia, say 3-4 marks, if you get a, so just write it out table wise, where are the chromosome on which the genetic mutation is occurring. Symptoms are more or less same, but definitions, again, reduced formation of alpha polypeptide chains or alpha, that globin chain in the alpha part or in the beta part. So these should be easy. If you know the substance, then you can make out these kind of tables by yourself. Just you have to know just means you have to know the substance. The major type of alpha thalassemia is hemoglobin buds, and major type of beta thalassemia, it's major, it is also called Cooley's or Mediterranean. Just to make more points, you can make other names buds, other names Cooley's and Mediterranean. So mention it like in the table. So if you know some information, relevant information, these types of table you can make by yourself. Something about sickle cells, it is also called HB, like HbA, it is variants of hemoglobin, HB capital S. So this type of shape, sickle cells, the structural abnormalities in place of in glutamate, valine position, in the beta 6 position of the globin chain. So valine instead of glutamate, again beta chains are involved, valine, so amino acid substitution. This is the most common we talk about, but okay, we'll come later. So sickle cell, this is this RBC, normal RBC with normal hemoglobin, but due to structural hemoglobin, these the shape of the RBC altered. Sickled RBC cells, not the normal. What shape of RBC normally? Biconcave. So sickle cells, it can't easily pass through, especially through the narrower blood vessels, capillaries, so it will cause obstruction. And again, whenever hemoglobin, any structural functional abnormality of hemoglobin, what is most hampered? Carriage of oxygenates to tissues, it will cause hypoxia. Hypoxia is reduced oxygenation at the tissue level. So sickle cells, it will not only cause, already due to sickle cells, this abnormal shape, abnormal structure, hemoglobin is breaking down. So hemolysis is occurring. So that is the major cause, that it can't carry oxygen. If hemoglobin breaks down, then how can it carry oxygen? So it will cause hypoxia, and even if some hemoglobin, whatever hemoglobin is remaining, abnormal hemoglobin, just understand, abnormal hemoglobin, most are breaking down. Whatever is remaining, if they can't pass through capillaries, then what will happen? So both due to cause of hypoxia is both the hemolysis, that is cause of less oxygenated tubes, both most hemoglobin are breaking down and whatever is remaining can't pass through capillaries. So that is the problem. So major problem is tissue hypoxia, that is hypoxia, oxygenation, less oxygenation at the tissue level. Pain episodes because of these sickle cells when they are trying to pass through these capillaries, wherever they are getting blocked, so this causes pain. So, but the main problem is less tissue oxygenation, and that causes major problems. It is cause fatigue, paleness, weakness. Jaundice will be due to again hemolysis, breaking down of hemoglobin. So, mostly the cause of less tissue oxygenation is hemolysis, okay. But it is also due to circulatory obstruction. Whatever normal, if some hemoglobins have still not broken down, but they can't pass through the narrower blood vessels, don't easily pass through blood vessels. This is how they look like. If objective structured questions are set, especially in the practical exam, you may get a slide like this, and just here maybe say it is labeled as say A or B, something like what is A, objective structured question. So this is a sickle cell, and it is probably pointing towards, this slide is probably pointing towards a diagnosis of sickle cell anemia or a sickle cell disease, okay. So again obstructive, the same things, vaso-occlusive crisis, hemolytic crisis, megaloblastic crisis, that is due to folic acid deficiency, but we will discuss about this. We will discuss anemia. There is one section on anemia, polycythemia, jaundice. We will discuss about this, but most important here is hemolytic crisis, rapid breakdown of hemoglobin. So, and whatever remains, they are occluded blood vessels, because the sickle cells can't pass through the blood vessels, narrower blood vessels. And blockages cause pain, inflammation, we have already mentioned. Some other variants, hemoglobin C, D, O, E, there are so many variants. Again, these names are just of historical importance. They were arbitrarily named one after the another as they were discovered. These have nothing to do with structural. These names, hemoglobin, A is adult hemoglobin, so C, D, E, I have not got in any text the mention of hemoglobin B or something. But C, D, E, O, all these are just named one after another. Later maybe somewhere again became obsolete because they were found to be same with another. So we speak of C, E, all these things. E is mode is these are due to the substitution of amino acids at some position at beta globin chain. Okay, substitution of amino acids. SC disease is combination of some sickle cells and some types of hemoglobin C, and according to if it is sickle cells from both traits, both parents and all, this is called hemoglobin SS. Those are most severity, in clinical severity, most difficult to tackle, and clinically more severe, more symptoms. So that is hemoglobin SS. SC is person inherits both HbS and HbC. Hemoglobin E is again, this is most common abnormal after hemoglobin S. So most common is probably hemoglobin S, but most common after hemoglobin S is hemoglobin E, and this is if you think about the state of West Bengal, it is more prevalent. Like we told that beta thalassemia major was first found, and those in those regions, these are more prevalent. That is prevalence of disease, that again depends on various factors. Prevalence of a disease, you will read about prevalence incidence of disease in community medicine, what they are. So those are not only if some disease is remaining in some population but undiagnosed, then it is prevalent, but that is undiagnosed. So those are separate discussions, but it is seen that those are most common in those types of populations. So hemoglobin C itself can cause mild anemia and splenomegaly, but the splenomegaly means enlargement of spleen. Whenever the spleen has to handle so enlargement of spleen, that is pathological. So anemia, splenomegaly will discuss in short in physiology, we will study in medicine why does this occur and all that, the physiology, not only medicine, before that pathology, that is splenomegaly, enlargement of spleen due in these cases, all these, but in mild forms only in case of hemoglobin C. Hemoglobin D again, glutamic acid to glutamine at position 121, hemoglobin O, these are mostly I think from mainly this maybe should not be set, but if someone sets MCQs, these are relevant, otherwise these are not very relevant. Hemoglobin O, again the most common among that is hemoglobin O Arab in that population. It is at I think position 121, yes, lysine in the beta globin chain instead of glutamine at 121. All these things are just for, some are for mostly for historical references, but these itself, these things themselves do not cause that major severity in disease, except hemoglobin H, again 3 of the 4 alpha globin chains are missing, that is will be more severe. Hemoglobin H we already mentioned during alpha thalassemia. See, hemoglobin H disease, 3 of the 4 moderate to severe disease, 3 of the 4, that is hemoglobin H. So, why it is hemoglobin H? Because already somewhere described as ABCDEF G, A is adult hemoglobin, BCDEF G, that is why they named it as hemoglobin H, when they found it out that 3 of the 4 genes may be different. Okay. So, again HBD trait, have I mentioned? Yes, it is in Punjab, and also in some texts you will find written it is more prevalent Punjab in India or this subcontinent. HBD, it is also mentioned at HBD Los Angeles. So, these are all historical and geographical importances. Okay. Glutamic acid to glutamine at position 121, just for referring to MCQs, but such MCQs should not be said. It is just in information based, which does not mean much. MCQs mostly should be concept based. So, info based, these are historical, this is nothing about physiology, well, in which population it is prevalent and all historical and geographical. Okay. This is again, we have already mentioned this HbS, sickle cell disease can be in combination. If it is HbSS, more severe, but in combination with hemoglobin E, hemoglobin O and all, then less severe disease. This is what this chart is mentioning in short. Okay. HbAs, sickle cell trait. If HbS is combination with beta thalassemia, beta globin chains are deficient, plus there are sickle cells, again obviously symptoms will be much severe, that is what they are mentioning. And this is the last thing we should mention, that this is hemoglobin A1c, that is hemoglobin A, this 1c is again historical reference. Okay. The third fraction, pure hemoglobin, what is pure? This pure hemoglobin A was classified as hemoglobin A0, then hemoglobin A1, ABC is the third fraction during separation, during these chemical methods and all. So, that is why it is named. It is glycated hemoglobin. The clinical significance is glucose is attaching, sugars are attaching to adult hemoglobin, and lifespan of RBC is 120 days. So, measuring levels of HbA1c, if it is as it is possible to measure in the laboratory, this gives an estimate of the average blood glucose over the past 3 months. And nowadays this is considered as the most important or most very good marker for diabetes mellitus, because fasting blood glucose, postprandial blood glucose, we will know about these things as you go on studying medicine. In the fasting state, if we measure blood glucose by taking blood, venous blood, collecting venous blood, then it depends on the patient's or the patient's history, subjects, the medical subject's history, because we are asking him or her, if it is in the hospitalized state, it will be probably better monitored, but if it is at home, say the subject, we are asking the subject fast for 10 hours, but probably maybe he has taken his dinner at 2 AM and taking blood at 8 AM. So, those are becoming false, that means false positive results may be there. Okay. So, best is HbA1c in that way, because that is not under the control of anybody, sugars are attaching to glucose, but again if there is some form of thalassemia and all these hemoglobin structural deficiencies and all these things, hemoglobinopathies, then that is not reliable, because hemoglobin A is very less. So, how can we rely on hemoglobin A1c? But in otherwise healthy individuals who have developed diabetes, healthy means does not suffer from something related to this hemoglobin structure functions. So, HbA1c can be a marker for, and it is probably nowadays the best chosen marker for, or marker means it is contributing to diagnosis of diabetes mellitus. It corresponds to percentage of 6.5 or more, it is probably corresponding to the symptoms and signs of what we are calling the disease diabetes mellitus. We will discuss a bit in, or you will know about a bit of it in physiology, in the endocrine physiology part, when we discuss about endocrine, pancreas and insulin, right. So, next session will be, I think, either on anemia, polycythemia or blood groups. Only 1 or 2 sections are left in hematology. We will complete that in the next 3 or 4 sessions, 2-3 sessions, 3 or 4 sessions. And it will, in the first internal assessment, the whole of this hematology, GI physiology, general physiology, hematology will be there, and most of CVS will tell you that.